This is on MUE edit. Okay, MUE, ME, sorry, MUI and MUE edit. And we'll be learning about what is CC edit. All the scenarios we'll be able to see in this particular topic, which is also one of the important topic in the domain one. Okay, so demonstration knowledge of medical coding edits. So there are different edits are there, CC edit, MUE edit, and CC edit, right? So those edit, even the medical necessity edit. So those are the things we are going to come across. A comprehensive guide to NCC, MUE, and medical necessity compliance protocol for the healthcare professionals and medical coders to ensure the proper reimbursement through mastery of regulatory coding standards and automated audit tools. So the first thing what we are going to come across here is NCCI edits. Okay, hope you might have came across this term NCCI edit. Okay,
Yes.
Corrective Coding Initiative edit.
Initiative.
What they do, what the main purpose of this NCCI edit. Okay, so they will ensure whether you have to code the CPT combinedly or separately, whether you need to code the CPT combinedly or separately. In terms, we can call it as bundling and unbundling. Okay, there are the procedures. So if I wanted to tell some example, which we have came across in the integumentary system, if you see, there will be a fine needle aspiration. Along with that, they might have used some guidance. There is a core needle biopsy. Along with that, they might have used some guidance. If you see, both the places guidance are common, but we have the combination code, a bundled code for fine needle aspiration with the ultrasound guidance. But if you see core needle biopsy with ultrasound guidance, we have to code separately. This becomes unbundling, where aspiration with guidance becomes the bundling. Even though we have the separate guidance code, I'm not going to code separately as per the guidelines. Okay, so sometimes we will not be able to come to the conclusion by just reading the description where I need to check the edits. Okay, where I need to check the edit, and that edit will indicate with some set of indicators that will make me sure whether I need to code with modifier or without modifier, or I need to use the unbundled CPT. That is one of the important thing. Okay, so understanding the NCC edit designated to prevent the improper payment and practice of unbundling in medical billing. So mainly for what? To avoid the unbundling. That is what very important in the National Corrective Initiative. See, we in general we call it as CC edit, but to be very precise, we have to call it as National Corrective Initiatives. Okay. Then NCC edit prevents improper payment when incorrect code combines are reported. In inpatient will, these are managed via MCE, which is Medicare Code Editor software, which is called MCE, Medicare Code Editor software, okay, which will tell you whether during the inpatient coding, whether I need to combine or bundle or unbundle, all will be indicated with the help of some indicator called, some software called Medicare Code Editor. Unbundling occurs when a coder reports multiple codes for a procedure when single comprehensive code exists. That is what very important. When there is a combined code, I cannot code separately. I need to use the comprehensive code. Then type of NCCI edits. Procedure to procedure is one type of edit, and medically unlike edit. So procedure to procedure means like number of CPTs you may encounter. In that scenario, whether I need to use a modifier, I should not be use the modifier, or I should code only one CPT, that decision will be coming based on the procedure to procedure edits. When it comes for the mutually unlike edits, it has a limit. How many times I can code this CPT? How many times I will be able to code this CPT for 1 day, per day? Okay, it will have something called mutually unlike edit adjudicator indicators, adjudication indicators, which is also called MAI. Okay, by using that adjudication indicator, you will be able to come to the conclusion like how many times I will be able to code this CPT for per day. Okay, that can be indicated with something called MAI, which we'll be discussing further with how many times, like what is the MAI indicator and how the indicator will be used, how the indicator will be noticed. Okay, first we'll see procedure to procedure edits. Okay, in the procedure to procedure edits, always it has a code submitted for the same patient on the same day by the same provider. Remember, Same patient on the same day by the same provider. If it is a different provider, just use the modifier and override. XP modifier is one modifier, we can override. If it is with the same modifier, we need to follow a rule. Now we have the software, different software, which we put these two CPTs together and we come for the conclusion, which need to be taken, which need not to be taken, which need to be appended with the modifier, or I should code only one CPT. Like that, we are coming for the conclusion. But manually, if you see something, Center for Medicare and Medicare, we have the Medicare services, we have the separate website where they'll be having the CCI editor, procedure to procedure, hospital to procedure indicator. You can download that manually through the spreadsheet and you can able to identify the CPTs. Okay. So here in that particular spreadsheet, what you're going to have is like two things. One is column 1 and column 2. Column 1 will indicate a major comprehensive procedure that gets paid, and column 2 minor component naturally included in the column 1. Okay, so in the two columns you are going to have the CPT set of CPTs. Like in column 1 you are going to have one set of CPTs, and column 2 you are going to have one set of CPTs, and third you will have something called modifier indicator, that is MUE indicator we call it as. Okay, medically unlike edit indicators, which is all 0, 1 and 9. Say for example, if I wanted to give one example for you, if you take I will give it from okay, we'll go for the diagnostic radiology. One view of chest X-ray, two view of chest X-ray. Both are chest X-ray. Both were performed by the ex-physician. Both are chest X-ray. Now here one view, lateral one view is there. In the two view, lateral plus medial is there. Now already this lateral is taken in one view, but again they have taken one more time. The lateral view has been taken. Now I cannot pay for the lateral view two times. I cannot pay lateral view for two times. Okay, to avoid that, what I will do, I will check for the indicator. The indicator will tell you can be bypassed with the 59, which means it will be indicated along with the one view code. You will be having indicator 1 that will tells you you can override with the 59 modifier, which means I will not pay double time for lateral view. I will reduce the payment. Say for example, one view 10 rupees and two view 15 rupees means now I will reduce the 10 rupees or 5 rupees and I will pay it as a together 15 rupees for both the procedure for that particular physician. So that is where you will see the indicator 1. Okay, so 0 indicator, you should be coded from the column 1. Whatever the CPT is indicated in the column 1, only that should be coded. If you take for one more example, if you wanted to tell for that, I will go with the surgery. Okay, same we can go. Fine needle aspiration. They are given one code. Okay, fine needle aspiration 111005. Fine needle aspiration. In the same column 2, they have provided 76942, which is like ultrasound guidance code. Now, these both will be indicated with the 0 indicator. In the third, there will be a third column. Okay, column 1, you will have the aspiration code. Column 2, you will have the guidance code, and one side, what is that, comments or remarks we can tell. There you will have something called 0, which tells you 0 means cannot be bypassed the edit. Only column 1 is paid, which means code only the fine needle aspiration. Do not code ultrasound guidance, which is present in the column 2. That is what 0 indicator is telling us. Then 9th indicator. Okay, here the edit is deleted or not applicable. Here if you see what it says, you have to code both. Same example we'll take. In the column 1, you have the fine needle aspiration. In column 2, you are going to have the core needle biopsy. Now both can be coded, and you may have the one more code, guidance code also. Guidance code will be there. Okay, as per your documentation. Fine needle aspiration with the guidance and the core needle aspiration with the guidance. Both have been column 1 and column 2 it is present. Now there is no problem because the guidance can be used for both. So I can code the both. So the 9 indicator says code both without modifier. Indicator 1 says code both with modifier. Indicator 9 says code both without modifier. Where 0 says 0 modifier. Only 1 should be there. 0 modifier. Nothing is allowed. Only 1 should be coded. That is what 0 is indicating you. And 1 is indicating apply any one modifier with the any one, which is like any column 2 or column 1 we need to apply. Especially column 2 we have to apply. 9 is like do not apply any modifier, code the both. Mostly this edit you will not be able to see in the ED, but when come for the E&M with a minor surgery, triggering injection, pain management injections, where you will be able to use these modifiers. Then the next thing is, sorry. The next thing is some of the scenarios, some of the CPTs I have provided here for the better understanding. See the zero, poly polypectomy and biopsy on the same lesion are never separately billable, because while doing the polypectomy, when I'm removing something, why again I have to do the biopsy? Think the logically. It is not only like you should be always, you have to go with the guidelines. If you put your experience and your knowledge and your the what is it, your common sense, if I tell, if you wanted to tell very precisely, if you deep think into your forehead, you'll be able to come to the conclusion. See, polypectomy is done, biopsy is done in the same area. What is biopsy? I'm going to take some tissue and send it for the lab. That is biopsy. Okay. What I'm doing in the polypectomy, I'm removing some tissue. Then same tissue I can send it for biopsy. No. Correct. In that scenario, why I have to code, you need to code biopsy separately, polypectomy separately. Biopsy will be default included in the polypectomy. Okay, where you will get a zero indicator where only polypectomy should supposed to be coded. Then indicator one, meniscectomy and synovectomy. Meniscectomy and synovectomy in separate knee compartment. Lateral side, they're doing the meniscectomy because there are so many meniscus is there. Okay, crucial meniscus ligament is there, anterior meniscus ligament is there. Okay, different set of meniscus is there. So here, what is the main thing? If I know basically the basic core knowledge of knee anatomy, I'll be able to differentiate, yes, in what part he has done the meniscectomy. Because it is not like only one is there meniscectomy. Only one meniscectomy is there. I don't want to worry about that. I don't want to use the modifier. I can code only the meniscectomy. And I need to code a synovectomy separately. Here, both are in different structures. Okay, both are in different approach. Okay, synovectomy is done in one place and meniscectomy is done in one place. In that scenario, I need to indicate that as a same area, different approach with the excess modifier, because both are different structures. So I'm indicating with the indicator one, where column 2 should be used with the modifier. Then carpal tunnel and arthroscopy. Carpal tunnel and arthroscopy, both are different procedure. Carpal tunnel is done in the wrist. Knee arthroscopy is done in the knee. Both are completely different procedure. So the indicator will be 9 only. So both can be coded separately. Okay. So these are the some of the example for this indicator. So I'm having some example in IPD as related also. See here, appendectomy, abscess drainage can be reported separately if documented. And zero, liver resection and liver biopsy. Yes, and I'm doing the resection. Why again I need to code for the biopsy. Then inguinal repair and the sigmoid colon excision, both are completely different exams. So no bundling, code separately. Okay. Then comes understanding of the medically unlike edits. So medically unlike edits, what is the purpose? As I told, we have something called MAI indicators that we'll be discussing in the further. Okay, so climb line MUE. So here if you see, we have different set of services here. First thing is like system check the each individual line, multiple lines for the same code and check separately. And the second thing, it will check for the DOS. Okay, how many times that unit, how many times it should be there. Okay, based on the DOS, how many times I'm supposed to be coded, that will be verified. Okay, this is one type of MUE. The third type is like MAI, that is mutually unlike edit, sorry, medically unlike edit adjudication indicator, which means like per day how many times I can be able to code. Say for example, if you see here MAI2, MAI1, so that is some double time it is there, ignore that. MAI1, okay, which is like never bypassed, you have to code only one time. Then MAI2, anatomy and policy limit, almost never bypassed. Then MAI3, clinical limited, standard of care can be appealed, which means this will give you different explanations when I can be used, after using, whether I can be coded 2 times or 1 times. If I'm coding 2 times or 1 times, whether that can be rebuilt, because some of the scenarios where I should be able to code 2 to 3 times also, but my adjudicated indication says code only 1 time. Okay, say for example, we'll take this, what is that? This carpal tunnel syndrome itself. Okay, one example. Okay, if they're done in both hand, it is different hands. But if you see the adjudicator indicator, it says we have to code only 1 time. But the procedure is done 2 times in 2 different hands. So I need to appeal it by using the indicator. Okay, by using the indicator, MEI indicator 3, which will explain, this can be coded 2 times. With the provider, we need to go back and check. We can be coded 2 times because it is a standard care which is taken for the both right and left hand. Okay, so some of the examples I have. Okay, some of the case studies I have given here. We see like code 1102. Okay, it is like the unit will be 2 times, modifier none, it will be denied. If I'm coding 2 times without any modifier, definitely that will be get denied. Okay. And if you see, if the indicator, if you use the indicator 1 there, right, or if indicator 1, okay, which means like I can override with the 59 modifier. So here what indicator you are saying is like how I am going to use the MA indicator 1. In MA indicator 1, when it says indicator 1, I cannot be able to use 2 times. If you use it for 2 units, 2 times, 1102, 1102, 2 times, skin biopsy code 2 times, it will get denied. Why? Because no modifier is allowed here. When I'm using with the modifier, see RT, LT, yes, that will get paid. Okay. Same way, if you see the second one, okay, that is like MA indicator 2, absolutely limited. Appendectomy 44950 limited is humans only have one appendix, which means I can do only one time only. First time only that will be billed. Second time and all I cannot use it. Okay, where this MAI2 indicator will tell you there is no more claiming or payment will be provided for any more appendectomy. Okay, that is what they're trying to tell. Code the definition, destructive lesion code 17000 for the first lesion limit is. So here for the first lesion, for the destructive lesion codes, 10000 I can be used. Okay, only one time I'm supposed to use. Since he is doing the lesion destructive 2 times, 3 times, I cannot use the second time, third time. It will not get billed. You have to use the add-on code for that. When you use the primary code again and again, it will get denied. Okay, which will be coming under absolute limit. There is no way I'm going to pay for this. What they're trying to tell, there is no way I'm going to pay for this. The first one, I can override with the modifier, right side, left side, 59 modifier, which will be indicated with MAI1. Means that when the CPT says 1, I'm happy. I can use the modifier. When indication, when the indicator says, when the CPT with the indicator MAI2, I cannot use any more modifier. I have to code only one time. When it comes for the 3, that is also limited only, but I can appeal one more time. I can go back and explain the logic. Okay, the surgery is done for so and so reason. So this can be coded 2 times. So that will be indicated with MAI3. So here something you will not be able to see manually. We have the manual indicator also. Software most of the time, say for example, Optum software or like Optum tool or Codify tool or Super Coder, Find a Coder. When you put the CPT under that, you will get these indicators. Based on these indicators only, where you can go for the modifiers, where you can code 1 time or 2 times with the modifiers or without the modifiers. Okay, that is what mainly this is speaking about. Some clinical scenarios. See here, bilateral procedure. Cataract surgery billed as 2 unit on one line is denied. Use separate lines with the 50 modifier. So if I use the 50 modifier, my cataract surgery can be billed. Why? Because it is a bilateral procedure that will be indicated with MAI1. Then MAI2, appendectomy, already we have seen. If you put 2, definitely it will not get billed. It will get denied because appendectomy should be with only 1 unit. Okay, that is what it is controlled with MAI indicator 2. Then medical dosage, MAI3 antibiotics claims of 15 units, limits 10 unit is flagged and required medical necessity. Yes, I can code 2 times and I can tell. Because if I have only one code, antibiotic for only one code with 10, okay, 10 unit, I can code 2 times. Now, when I combine 10 plus 10, it becomes 20, but it is given only 15. Now, I can provide some proof, medical proof stating that for this particular CPT, I have done so and so. I have done so and so. Do make sure this need to be coded, billed, or paid twice. And payment should be gone according to the units they are used. Okay, that is what this entire medically, okay, necessity edits stays for. Okay, which is completely comes under NCCI edit. Okay, under the medical necessity edits only we will be having the CC edit. Under that medical necessity edit only we will be having the LCD edit under the NCD edit. Mostly we study this separately. We think like, okay, LCD is separate, NCD is separate, or CC edit is separate. Yes, those are separate, where LCD and NCD will be used for the ICD purpose, where CC edit, which means NCA edit, is used for the modifier purpose, for the CPT purpose. Okay. So, but these both are coming under the medical necessity edits. Under the medical necessity edits only, you will be getting some kind of criteria, some of the indicator criteria, which is MAI, which is mutually unlike edits, or medically unlike edit adjudication indicator. Okay, so far what are we are seeing is like medically unlike edit. Now we are going to see medically necessity edits. Okay. So medically unlike edits, medically necessity edits. So here medically necessity edits means LCD and NCD. Here NCD focus on medical necessity, explain who qualifies and which codes are covered. Service without matching ICD 10 CM diagnosis are considered not or are considered not medically necessary. LCDs are governed by local coverage determination at the region MAC, medically administrative contractor level. We call it as MAC. Okay, so here, what is the major difference between the NCD and LCD? There are certain ICDs where it will be covered across all the state. The rule is same. Okay, we can imagine in our country, there are two different governments are there. One is central government and the state government. LCD is like a state government, which it has its own policies to make the payment for the medical necessity ICDs. Okay. And there is something given by the central government, right? Which is like all the states should be followed. Default your LCD, something provided national coverage determination, which across everybody should be followed. Like if you see some of the condition, cancer related condition, conditions related to the diabetes, because state to state you don't follow separate diabetes. For all the state, same diabetes only. For cancer, state to state, don't follow any cancer related things. All the states should follow the same cancer guidelines only. Like that, certain conditions will comes under the national coverage determination. Certain conditions will comes under the local coverage determination. If you see for local coverage determination, in Kashmir, you may get pneumonia very often. In Tamil Nadu or Andhra, that is possibility is less. So that is how it became the local coverage determination. Pneumonia is very common there. Pneumonia is not common here. So to make that medically necessity, if I get a pneumonia in South India, they will give preference for that. I need to pay more. But the same pneumonia is there in Kashmir, I don't mind that much. I will not pay full money. I will pay only half money because pneumonia is very common there for all the people. Okay, that is how the state to state, the local coverage determination will differ, which will be taken under based on the administration called medical administration contractor. They will decide which conditions, which diseases, which ICD should be coming under LCD. So first thing is like some of the example for NCD, as I told, diabetes like blood glucose, that will be common. Then colonoscopy, yes, that will be common. Okay, if you see that 190.10 is article, NCD article, we call it as policy article, that will explain to all the state it need to be followed. Frequent rule every 10 years for average risk, every 2 years for the high risk patient. So some kind of guidelines will be there under that policy, under that article. Okay, same way we have the different articles for blood glucose and we have for stem cell, okay, which is need to be followed based on this policy under all the state. Okay, so now mastering of the coding edit for the compliance. So this is what we have for the LCD and the NCD and for the MUE edit. Okay, so these all are very important for the compliance, okay, which we need to be very careful when you're using this particular modifiers or which we are going to follow for the NCD and NCD. In the exam point of view, the question may come for you as a guidelines instead of coming as an edit. They are not going to ask for the modifier base. They're going to ask the guideline basis. Okay, that will be very straightforward only. You will be able to answer that as well. Okay, so this is what we have for the MUE edit and MAI indicator and for NCC edit and for the CCA and LCD and NCD edits. Okay. Okay, I will stop the class here. Okay, so remaining topic we can discuss tomorrow. Okay, so remaining we have a few more topics to discuss, not like few more, I have domain topics, like domain 2 topics are like documentation. Coding documentation is one of the topic where it will be covering for the identifying and correction gap and what is it, medical record documentation are completely related to the documentation. So this is something like questions, minimum 10 questions will come from this. Okay, we need to pay a lot of attention towards that. Then provider query, that is a third domain. Okay, completely related to the provider queries you will be able to get. Then you will be getting for the regulatory and compliance. I will provide the notes for that. Same time I will provide explanation because this regulatory and compliance will have the vast subject it is. Okay, you will have these hospital acquired conditions and the medical integrities and this, what is that, knowledge and OIG, office, what is that, office information, something, it will go OIG. Okay, then UHDDS requirement. This all will comes under the, what is that, this regulated compliance. Then we have something on information technology. It is very easy one. Simply we can complete that topic. Okay.
Okay.
So each it may take 2 days. So within some 4 domains means maximum 5 to 6 classes we can complete it off. Okay. Okay, I will stop the class today. We'll continue tomorrow. Okay, whatever recordings is there, once it is generated, I will share you more. I think till yesterday I shared you till the 3 series. Just get the access. Okay, I will provide access for that.
Okay.
Okay, and gentle reminder on the remaining payment, Buna.
Okay,
Please
sir.
make sure like soon you can able to pay. Please try to pay it. Okay.
Yes.
Okay. Thank you, Buna.